Hey, good evening. Welcome to Here's to Your Good Health. My name is Linda Prezioso. I'm a nurse practitioner at Family Medical Center, and I'm so excited because we have a new kid on the block, so to speak. Dr. Clay Nelson is an orthopedic surgeon, and he has come and joined the UNC, is that what we call it? The NASH UNC Orthopedics. You know, there's some big names around here that, but anyway, he's new to us. He's been here since August, but the clincher for this whole thing is he's a Rocky Mount boy, and his daddy is Dr. Greg Nelson, and I'm sure all of you have heard of him because Dr. Nelson and Dr. McAvoy have been around for quite a while, and they've been in practice together. And so Clay Nelson has come back home, so to speak. So you know, you're our second Rocky Mount physician that came back.
That's right.
Yeah.
Yes, ma'am.
Yeah, Stephanie Martin did too.
I know, she's good. She's actually my neighbor. We've
oh, okay.
been hanging out a lot.
Yeah, she's real sweet.
Awesome.
Yeah, she is.
She's really good.
So welcome to Rocky Mount.
Thank you.
And welcome to Here's to Your Good Health. We are just so excited to have you with.
Thank you. It's been great so far. I started in August, and it's been busy, and it's been good to be home.
Awesome, awesome. So you were obviously raised here. Your dad didn't send you to military school or something, did he?
No, I went. So we moved after my dad finished residency. I was born down in Atlanta when he was completing residency, and then we moved back to Rocky Mount when he started the practice, and I grew up here and went to high school here, and then after that went to Carolina, but all, you know, grade school and everything.
Tar Heel.
That's
my
right.
kind of man.
Exactly.
I like the blue over at the hospital.
I know, me too. That's the only reason I chose it.
That's right, that's right. So where you went to Carolina for undergrad?
Yes, ma'am.
Where did you go to medical school then?
So I went from Carolina, I went to Eastern Virginia Medical School, which is in Norfolk, Virginia, and did 4 years there. And then after that, I went to residency in Memphis at the Campbell Clinic. And then I did an additional year in sports medicine in Jackson, Mississippi.
Wow.
So I made a big circle.
Yeah, you sure did. You sure did. And North Carolina is just, it's in your blood, isn't it?
It is.
I know.
That was like one of the things me and my wife wanted to, that was one thing on the list. We wanted to be in North Carolina when we started looking, and here we are. Is she
from North Carolina as well?
So we met at Carolina, but she kind of grew up all over the place. Her dad's in the military, and her mom's actually German. So she actually grew up mostly in Germany.
Oh, okay.
So,
well,
I know.
Boy, you got an international family going on here. That's awesome. Yep. So you've been here since August, and you do you have regular hours? Like, what are your office hours? So
I'm in clinic Monday through Wednesday all day. My OR day is almost every Thursday at this point, and then I have from 8:30 to 1 o'clock on Fridays.
Okay.
And then the office closes.
Yeah, I think most offices, except mine.
Yeah. You gotta come over and work with us.
Well, I'm off on Fridays, so I really can't complain.
Yeah.
So let's see. I've got some questions here, but so tell me, what exactly is sports medicine? What does that mean? So
sports medicine, I mean, it encompasses a lot of things, but the easiest way to explain it, my fellowship was mostly in arthroscopy, so being able to do a lot of surgeries with ligaments and soft tissues using a scope or an arthroscope. And so that's what my fellowship focused on. So doing essentially almost all of our surgeries through the camera, through small incisions in the elbow, shoulder, hip, knee. And so that's probably the easiest way to explain it.
Okay, all right. I had an arthroscopy surgery years ago with Dr. Jones, who used to be with your dad. I can't remember his first name, but I think he's in Raleigh now.
Yeah, Rob Jones.
Rob Jones, that's right, that's right. Yeah, that was quite a while ago.
I know, he's in Raleigh now, so, but.
Yeah, isn't that awesome? So what's your favorite part of all of it? I mean, I know that, you know, you love all of it, but you must have, is it the knees and the arthroscopies, or? Yeah,
so the reason I actually chose sports medicine, so in residency I felt like I got pretty good exposure to everything, but I felt sports medicine in general was more of a general orthopedist fellowship. So I did sports medicine because I feel like you can kind of reach a lot of the demographics. So from you know, early ages all the way up into, you know, the retirees that want to get back and play tennis. And arthroscopy, you know, it takes a while to get good at, and so I wanted to spend an additional year really kind of you know, perfecting everything and making sure when I got into the community that I was, you know, prepared to take on, you know, big surgeries and feel comfortable. And so I think it definitely prepared me for that.
Yeah. I hope we can get back to regular sports again.
I know, it's definitely
not that I want any knees to be bad, but you know,
Yeah.
that's where a lot of that comes, is from my son had to have that years ago when he played soccer.
Yeah, I think, you know, before all this started, when football season, I mean, you would usually see an ACL or two every week.
Sure.
And, you know, they're just not there right now. But hopefully this, you know, COVID and everything's kind of, you know, hopefully will start going down.
I am really over it.
I know, I think everybody is.
Yeah. So, and you might not know this, this is off my top of my head.
Sure.
Do you know the statistics or the ratio of, like, let's say, you know, 18-year-old arthroscopy off the soccer field and had to have a ACL repair? Because can he do well, or is he going to get arthritis 20 years down the road, or?
Yeah, so all the literature on ACL tears, it's a little confusing because people that do have ACL reconstructions actually are a little bit more likely to get arthritis down the road, but it's hard to tell whether it's because they tore their ACL or if they're just the type of people that are, you know, out there, you know, doing more physical activities or, you know, using their. So you are a little bit more likely, but it doesn't necessarily because you tore your ACL.
Okay. That might just contribute to it.
Yeah.
Sorry, that was off the cuff here.
Okay.
So, how long have you wanted to be a doctor?
For a long time.
Yeah.
Yeah. So, I mean, growing up with my dad here, I mean, for as long as I can remember, you know, Saturdays, if it wasn't football season, you know, it was which child got to go and go round with him in the hospital. During football season, he actually had a free clinic for athletes.
Yeah, I remember that.
And so we would go and help out and just kind of see the athletes. So it was always, you know, really important to me to, you know, spend that kind of time with them, and I luckily got that exposure early. And then growing up, you know, as I got a little bit older, I was able to get into the operating room with him, which was an awesome experience for me. And then, you know, being on the sidelines, you know, for football games and things, and seeing him evaluate injuries, it was just always something that kind of fascinated me.
What about your siblings? Either one of, I don't know how many you have.
Yeah, so I have 2 older brothers and a younger sister, and we're all connected to medicine.
Are you?
Yeah, so my oldest brother, he sells orthopedic implants, so he sells total hips and total knees in Georgia. My middle brother, he does family medicine, sports medicine in Georgia. And then my youngest sister, or my sister, she went to PA school and just started working for an orthopedist in Greensboro.
Oh, wow.
This fall.
Everybody's in with the bones.
Yeah. Now if we can all get them to come back to Rocky Mount, would be.
Yeah, that would be great, wouldn't it? You could have a dynasty. That would be
nice.
awesome. Yeah. So, your wife was from all over, and she was born in Germany. How did she choose Chapel Hill as her college?
So it's an interesting story, but so when they had recruiters come to she went to American high school in Germany on the base there, and so the recruiters that would come were mostly based on, you know, the eastern part of the state, so North Carolina, Florida. And so it was just kind of what she was exposed to. And when she came over, she was actually in Florida to begin with, but her boyfriend at the time went to Duke. And I think that had something to do with why she migrated up this way. But luckily that didn't work out for me.
That's right. And who wants to hang with somebody that likes Duke? Sorry for all you Duke's fans out there, but you know, I bleed Tar Heel blue. My undergrad is at Chapel Hill as well. So, so how many are in the group now?
So there's 6 of us now.
Okay.
So Dr. Marsigli still seeing a couple patients in clinic. He's not operating, but he is actually a very good resource because he's been here since the 70s and he's seen it all.
Yes.
And he helps for, you know, if we have an interesting case or something that we just want an extra hand with, he comes into the operating room and he teaches us and kind of gives us good pointers.
I think that is awesome.
Yeah,
that is a really blessing.
I know, it's been really good for me and I think everybody in the group. And then my dad, Dr. McAvoy, who have been there the longest, and then more recently we have Dr. Hasty who does trauma, and then Dr. Strickland who does spine.
Oh, okay. I didn't even know about Dr. Strickland.
Yeah.
You're sneaking them in.
I know, they're just adding them left and right.
That's great. So when you say spine, what does he, would he do a microdiscectomy?
Oh, yeah.
He
yeah,
would, okay.
Yeah.
Doesn't have to be just a neurosurgeon.
Nope. So
I did not know that.
Yeah, so he doesn't do, you know, neurosurgery. They do some of the, you know, stuff for the brain and everything, but orthopedic spine is just, you know, pretty much all spine. And Dr. Strickland does some general orthopedics too.
Okay. So I can send all my backs to him.
Come on.
Every one of them, right? I had no idea. How long has he been there?
He started just a year before me.
Okay, I don't know where I've been.
I know. He's got to get on the show.
I know. Yeah. Yeah. He does.
Next week.
Next week. There you go. That's it. So you all are in a new building now, right?
We are. And it's been really nice, especially for me, because when I came, the office we were in was really made for 3 or 4 providers. And being the low man, I was stuck in some closet in the back by some file cabinets. And so now the office we're in is much bigger. And so I have my own little space, which is nice.
Yeah, and you can accommodate. There's a lot of people that come through when you've got 6 providers there.
Yeah, so it's been awesome. It's way more spacious, and then probably the best thing about it though is part of the outpatient physical therapy is now located in the building with us.
Oh, that is good.
Which is really awesome, because before they had to go into the hospital, but now they're able to come to our office, and it's really nice because especially for, you know, the therapist and us too, if they run into an issue or a question, they just walk over and ask us.
Yes.
And they're all great. They're
Now, is that Nash? Is that part of Nash? Their physical therapy?
So it's all the therapists that were within the hospital. About half of them now are in the outpatient clinic with us.
So there's still some at the hospital.
Yeah, and there's some. I don't know exactly how they do it, but they rotate, you know, back and forth depending on who needs to be where and what day.
Yeah. Boy, physical therapy is just such an asset, isn't it?
Oh, they do awesome work. I mean, they really, I mean, surgery is one thing, but I think their job's harder, you know, because they have to deal with, you know, all the issues, and they do a great job.
Yeah, they do. And it's amazing. I had kind of a shoulder thing going on, and I went to physical therapy, and after 2 sessions I felt 100% better.
I know.
You know, I went for a couple more just to make sure, because I sit like this, that causes problems, and I'm old, that causes problems, but yeah, I've really learned more to appreciate physical therapy.
Oh yeah, you know, it's always a worry when you start a new job, is kind of, you know, who you're going to be working with, you know, even behind the scenes, but I mean, everybody that comes in that's been to therapy has had awesome things to say about them, and so I try to let them know that they're doing a really good job, and they make my job a lot easier because they're so good at what they do.
That's good. That's good, because everybody needs a pat on the back. No matter how good you are, you still got to kind of, it's just nice to hear. So, yeah, that's great to have it right there in your own building. Yeah, so you can say, Linda, you got this knee thing, you need to go next door and set it up right then and there.
It's nice. You don't get all the, you know, oh, nobody called me about going to therapy. When they walk out, they can schedule their first appointment. And I mean, a lot of patients, you know, I give people the options because there's a lot of good places in the community to go to, but I feel like a lot of them feel more comfortable just knowing that they're within the building.
Oh yeah, I would think that if they put their trust in you or one of your peers, that would just make them feel more comfortable. That just makes sense to me. I think that's great. So are there anybody else in that team concept kind of? You've got your orthopedics, and you've got your surgeons and your docs and your physical therapists. Is there anybody else over there that?
Yeah, I mean, that's pretty much everybody in the office, and then, you know, the staff at Nash, you know, at the hospital, they're all really good. So I've been really pleased at all the help in the operating room, all the nurses on the floor. Everybody does a really good job, and it's been really a good experience for me, you know, because you never know when you get somewhere how people are going to be, but everybody at Nash seems to be willing to help, and that seems to be a big priority for everybody.
Well, it's a top-notch hospital. It just amazes me that little old Rocky Mount has such, really, they have such outstanding health care here. They really do.
Yeah,
it's
we're
so
lucky.
Nice. We are. We're very lucky. So have you done any knee replacements since you've been here?
So I haven't done any knee replacements. I've done a few total hips and some shoulder replacements.
Okay.
I think my dad and Dr. McAvoy are still keeping all the knee replacements for themselves.
That's all right. Let them have them.
Yeah, but they're sending me a lot of good stuff, so I cannot complain.
So what's the difference between, there's an anterior approach for a hip replacement and a posterior?
Sure. Which
is better for the patient, or is it individual?
So people will tell you a lot of different things. Certainly probably posterior approach is most well known, probably for most, you know, up until recently was what everybody did, and then recently the new, you know, hot topic is doing anterior approaches, and I think either one's a very good option, and I think it depends on what you're comfortable with, and if you do a good posterior approach or a good anterior approach, either one does really well. I do an anterior approach just because that's how I was trained, and that's what we were doing, and that's what people are interested in having been doing. And so essentially what that is, instead of going, you know, through kind of your buttock muscles, you go in from a smaller incision in the front near the groin, and it's muscle sparing, so you don't have to split any muscles. I think the one advantage I think to that is I think people feel probably a little bit more comfortable right after, and I think it makes the early rehab potentially a little bit faster. But I think both of them do really well, and so, you know, in our group everybody kind of does stuff differently, but I think all of them are good. The anterior approach I think maybe has the benefit of the patient's feeling a little bit more comfortable early.
Well, you know, the less muscle and tissue you can cut through, the better off for the patient.
Exactly.
So that's right. Okay. So how do I know if I need a hip replacement or a knee replacement?
Sure.
What do we do? How do we do it?
Yeah. So so the first step is, you know, if you start having, for hip replacements, usually patients have groin pain. So when I see patients in the clinic, if people are complaining about groin pain and they're at the age where hip arthritis is most likely, that's probably what it is. Some people with buttock pain or pain kind of in the back, sometimes that's coming from the back, but usually people that have bad hip arthritis feel it in their groin.
Okay.
So
that's good to know.
That's usually how people, you know, start to experience their pain. There are a couple options we can do before we get to surgery. There's some injections we can do that can help make people feel better without going to the extent of doing a hip replacement. But eventually sometimes that doesn't work, and people get tired of hurting all the time, and eventually their function and their daily living is affected by their pain, and at that point that's when we need to talk about doing a hip replacement. And same thing for a knee, you know. Usually people have medial arthritis, so pain on the inside of their joints, you know, pain with walking, pain at the end of the day, stiffness, and there's a lot of things you can do for knee arthritis to kind of buy some time before you need a knee replacement. But when it starts affecting your quality of life, then that's when you start to need to think about getting something done.
Yeah. All right, it's time for our first break. We're a little bit early, but we're going to go ahead and take it because this is a great time to break. So we're going to go to our first commercial. If you have any questions, think about them, and you can give us a call, 1111. And we'll be right back with more of Here's to Your Good Health with Dr. Clay Nelson. Don't go away. We'll be right back.
At Downey's Hearing Care Associates, we are dedicated to taking care of every client by providing personal, high-quality hearing care services. My staff and I know hearing loss affects each person and their loved ones differently, so we give you the time and the care you need to ensure the hearing technology chosen fits your lifestyle. At Downey's Hearing Care, we also make custom ear molds and specialize in emergency hearing aid repairs. Downey's Hearing Care Associates has 2 locations, one in Knightdale and one in Rocky Mount. We have hearing lives to save.
Hi, I'm Richard Koss, pharmacist and owner of Almonds Drug Store here in Rocky Mount. Here today with my wife and 2 daughters. For over 75 years, Almonds Drug Store has been the pharmacy of choice for residents of Edgecombe and Nash County. Our family is proud to call Rocky Mount home, and we are excited about the new services and products we are adding daily at both of our Almonds Drug Store's locations and also at our medical supply store.
Come in and see us at Almonds Medical Supply. We're an extension of Almonds Drug Stores, your local hometown pharmacy. We're here to service all your needs, from wheelchairs to walkers to orthopedic support to compression hose to hard-to-find wound care supplies. And you'll always get that hometown customer service.
We want our patients to pay the best prices, get the best service available, and have a better pharmacy experience than they will get anywhere else. Our staff is committed to going above and beyond to meet our patients' needs. Whether it is working with your provider to get you the best medication at the best price, contacting your provider to get you refills or a prior authorization, or taking the time to review each of your medications with you personally, or perhaps even helping you find an old-time remedy or other hard-to-find items, your Almonds Drug Store staff will work hard to meet your pharmacy needs. At Almonds, we will deliver your prescriptions for free. Both of our stores have drive-through windows, we guarantee short wait times, and our pharmacists will come out to greet you personally and answer any questions you have. If you want to be met with a smiling face, or even want someone to greet you by name when you walk through the doors, we are the pharmacy for you.
Call Almonds Drugs today.
443-3138 or 446-0014.
Well, hello and welcome back. This is Here's to Your Good Health. I'm Linda, and we're sitting with Dr. Clay Nelson, who is an orthopedic surgeon. He's been in town less than a year, but he's a Rocky Mount boy and he's come back home. So we're delighted to have him and delighted to talk about orthopedic problems. You know, everybody's got a knee pain or a back pain, or I think back pain is the most common complaint in a medical office.
Yeah, it is. It's very common. It's very nice that Dr. Strickland's with us, because he, if I ever have questions, he's a good resource, and he's an excellent surgeon. So he's been really nice to have.
I'm excited to learn about him. I didn't know about him. I feel like I've really been a disservice to my patients, but I'm on it now.
There you go.
All right, let's talk about shoulders. We talked a little bit about knees. We talked a little bit about hips. Now, shoulders, both, they can be replaced too. If you've got a joint, it can be replaced. I think that's
pretty much. Yeah, that's to the where we're getting to. But certainly there are shoulder replacements. There's also a lot of options that we can do with the scope. Depending on just what the problem is. Obviously, if it's more of an arthritis issue, then you're going to talk more about replacement. If it's a rotator cuff issue, a lot of times we can manage that without having to do a replacement. So doing a scope surgery and a repair, and addressing some of the pathology in the shoulder. And then, for really bad cuff tears, there's even a reverse shoulder replacement, which essentially just changes how the physics of the shoulder, so you can get away with replacing the shoulder without having an intact rotator cuff.
Shoulders are so complex. Golly.
They are.
I just, when people come into me, I'm not big on orthopedics, and when they come into me with shoulder, I'm like, oh. Naprosyn and physical therapy. If that doesn't work, they go to the orthopedic surgeon.
That's perfect. I like that plan.
So, but you inject shoulders as well as knees and hips, don't you?
Yeah, so depending on what the hip problem is, sometimes we'll send that to the radiologist, just because some of the hip injections need to be done with some sort of image guidance, so either ultrasound or under an x-ray machine. And so for hips in particular, we're sending some of those to our radiologist just to confirm that we're putting the injection in the right spot. But shoulder injection, elbow injections, wrist injections, pretty much everything else we can do in the clinic.
Okay, and that's pretty standard where you insert the, I chose not to learn about those in my training.
Yeah.
I can be selective.
Yeah, no.
So, is there anything new on the horizon as far as injections in joints? You know, I mean, we've been Decadron and lidocaine for 30 years or more.
Right.
Is there anything new?
There are some special type injections, especially for early arthritis, especially for the knee, where it's a type of gel injection that you put in the knee, and depending on which one you use, they're either one injection or they're a series of 3 that we can put in the knee and essentially buy you some time and give you some pain relief and hopefully put off a knee replacement for a while. And depending on insurance and co-pays and things like that, oftentimes we can do those in the clinic.
Okay. What about stem cell? I know that's kind of on the horizon, but it's insurance doesn't want to pay. It must be really expensive.
Yeah, there hasn't been any good data out there saying it makes a lot of difference. So I tend to stay away from that just because it's never been shown to really make a huge difference and it's very expensive. So we don't do that in our clinic. Certainly there are people out there that will do it, and some people swear by it, but
it's like anything. You know, what works for me is not necessarily going to work for you.
Right, exactly.
So that's the thing with that. And if it doesn't have the evidence behind it, if it hasn't been well studied, then it's, in my opinion, I agree with you, stay away from it.
Yeah, I think it's too early to know.
You know, there's always somebody who wants to be on the cutting edge of everything.
Exactly.
So, all right, let's talk about COVID. I'm so over COVID, and I know you are. So, has that cut back on the surgeries? Because I guess like knees and hips, they're elective, right?
Right. So Nash has done a really good job about, you know, making sure everybody that's involved in a surgery is protected. So especially for elective cases, you know, initially when everything started, we essentially cut out elective surgery pretty much everywhere in the United States. And obviously because COVID continued, elective surgeries needed to go on, and I think Nash has done a good job of trying to protect everybody at all levels. So for elective cases, everybody who's having an elective case gets tested 48 hours before and essentially quarantines for 48 hours until they come into the hospital, essentially, you know, protecting them, but also all the staff members that are involved, all the OR staff. And so, you know, pretty much everybody that has elective surgery, we know for the most part, know one way or another whether they have the virus or not. It has, you know, occasionally we've had asymptomatic patients that we have to, you know, delay their surgery for 3 weeks because they've had COVID. And that's always disappointing because you make a lot of arrangements to have your surgery on a certain day, and then you don't have any symptoms, and then you're essentially forced to quarantine and then have your surgery later. But you know, that's the safest way to do it.
Oh yeah, we have to think patient safety.
Right. And so, and then for inpatient, you know, procedures, people that come through the emergency room, the nice thing is that now that we have the resources, everybody that is admitted to the hospital gets COVID tested. And so if you're positive, you go to a specific wing of the hospital, and there's, you know, depending on how sick you are, depends at which level you go, but you know, every person in the hospital, patient-wise, we know if they have COVID or not, and so that helps us kind of protect everybody in the hospital.
Right. I bet that COVID wing is busy.
Yeah, it is.
Yeah. Aren't you glad you're not doing that stuff?
Yeah. Unfortunately, sometimes people break their hips and have COVID, so
Yeah,
I occasionally have to wander down those halls.
Right, right. So, Nash General is very big on getting, you know, service of excellence and distinctive. Like you have the Blue Distinction Center for total hip and knee.
Right.
Did you work in other hospitals when you were getting your training? Did they have that as well?
Yeah, I think that's a goal pretty much any hospital that's doing joint replacement kind of wants to achieve, and it's essentially saying you're having really good outcomes, but also a very low complication rate, and not having readmissions after your surgery is really important, and so that's how you get that distinction, is having very good outcomes with very few complications. And so I think it's every hospital strives for that, and Nash is lucky that they've been able to get that distinction. And so I've worked in a few hospitals that have had it, and I think it says a lot about kind of the commitment to safety and patient outcomes.
Yeah, yeah. It's important to have all of those things. I know that it gets to be problematic, especially from the nursing perspective, but I know how important it is. So anyway, we oh, here, see, I didn't even read that. It said highlight the anterior approach. See?
Yeah, you're all over it.
We're all over it over here. That's right. So we talked about that, and we talked about the rehab. Safety measures. Do you have specific safety measures coming into your office? Like if people have to, we screen them, ask them questions, and we take their temp, and you have that as well?
Yeah, so before every office visit, the day before, or when you're scheduling your appointment, they go over a list of questions, asking about if you've had COVID or had symptoms of COVID, and then, when you walk through the door, you're getting your temperature checked and also getting screened again. Same thing for everybody that works in the office. Everybody gets their temperature checked and wears a mask and goggles and tries to protect themselves and everybody around them the best we can.
Yeah, we do that too. So I'm so over it. Just so over it. Let's see. Talked about that. What do you want to talk about? What's the best part of being a doctor?
The patient interactions, for sure. I mean, it's obviously, every day I get to meet new people that may or may not ever have had the chance to meet, and just hearing their stories and kind of how they got to where they are and different experiences and, different problems they've faced along the way, I think has been probably the most rewarding part. And then, also, listening to them and hearing their problems and trying to come up with a treatment solution that fits kind of their goals and their needs. I think that's the challenge and the fun part about being the doctor, but it's not always cookbook, and you have to kind of accommodate people's needs, and even though you may want to try to do something one way, some people have restrictions on their job or things they have to do, and you have to kind of adapt your plan, and I think that's what makes it interesting and challenging.
Right, because it's not cookie cutter.
Yeah.
Everybody's different. Everybody has their own thing. So is hips your favorite thing to do?
So actually shoulders are probably my favorite. And so luckily, over the past few months, the rest of my partners have kind of given up their shoulders, so that's been a big part of my practice so far, and probably 70 to 75% of what I do so far is shoulder arthroscopy. And so it's been nice to kind of become more efficient and kind of become better at being a good shoulder surgeon, and I think that's been probably the best thing so far.
So are there still Like I remember years ago, and I don't know if it's changed, if you have a humeral fracture up here, all you do is sling it.
Yeah,
That's still about
for
it?
the most part. So depending on, age and the fracture itself, a very high percentage of them can be treated with just a sling for proximal humerus fractures. When they become more complicated, depending on the age and displacement and bone quality and things like that, then fixing them or even doing a replacement for some of the really bad ones in older patients do better. So it really depends on kind of the fracture and the patient, and there's a lot of options, but probably the vast majority get treated without surgery.
Yeah. How about clavicular fractures, the same thing?
Yeah, so 10 years ago, if you were to ask anybody, there would be no question that everybody just got a sling. Nobody ever got it, had an operation for a clavicle fracture unless it was open. But now, again, depending on age and kind of displacement and things like that, a decent percentage of clavicle fractures are now getting fixed for the really displaced ones.
Okay. Let's talk about what's an open fracture.
Open fracture when the bone comes out of the skin.
That's bad.
Yeah,
That's
not
really
good.
bad.
So the infection rate goes up, complication rates go up, healing rates go down. So it becomes much more complicated when the bone comes out.
Right, yeah. And does that happen probably mostly with trauma?
Yeah, it's usually high energy trauma that it happens. You occasionally have some ankle fractures or wrist fractures that are just simple falls that become open, but they're usually high energy trauma, so falls from heights or car accidents or things like that.
Yeah, we can really mess our bodies up, can't we?
Yeah, we can.
All right, well, it's time for number 2. We'll take a break and then we're going to come back and finish up.
All right.
So again, if you have any questions, give us a call, 407-1111. We're going a little bit early, Lee, and we'll be right back with Dr. Nelson and everything you ever wanted to know about orthopedics and orthopedic surgery. Don't go away.
At Downey's Hearing Care Associates, we are dedicated to taking care of every client by providing personal, high-quality hearing care services. My staff and I know hearing loss affects each person and their loved ones differently, so we give you the time and the care you need to ensure the hearing technology chosen fits your lifestyle. At Downey's Hearing Care, we also make custom ear molds and specialize in emergency hearing aid repairs. Downey's Hearing Care Associates has 2 locations, one in Knightdale and one in Rocky Mount. We have hearing lives to save.
When faced with special care needs for elderly or disabled loved ones, families want compassionate, comforting care. That's Tender Touch Home Care Services' goal, providing the level of care we would expect for our own. With over 10 years of home care excellence, Tender Touch provides an array of services that keeps your loved one at home. From personal care, light housekeeping, errands, and meal preparation, to our private duty care program, which combines all of our home care offerings in one package.
Tender Touch Home Care Services, where your needs are our concern.
Hi, I'm Richard Goss, pharmacist and owner of Almonds Drug Store here in Rocky Mount. Here today with my wife and 2 daughters. For over 75 years, Almonds Drug Store has been the pharmacy of choice for residents of Edgecombe and Nash County. Our family is proud to call Rocky Mount home, and we are excited about the new services and products we are adding daily at both of our Almonds Drug Store's locations and also at our medical supply store.
Come in and see us at Almonds Medical Supply. We're an extension of Almonds Drug Stores, your local hometown pharmacy. We're here to service all your needs, from wheelchairs to walkers to orthopedic supports to compression hose to hard-to-find wound care supplies. And you'll always get that hometown customer service.
We want our patients to pay the best prices, get the best service available, and have a better pharmacy experience than they will get anywhere else. Our staff is committed to going above and beyond to meet our patients' needs. Whether it is working with your provider to get you the best medication at the best price, contacting your provider to get you refills or a prior authorization, or taking the time to review each of your medications with you personally, or perhaps even helping you find an old-time remedy or other hard-to-find items, your Almonds Drugstore staff will work hard to meet your pharmacy needs. At Almonds, we will deliver your prescriptions for free. Both of our stores have drive-through windows, we guarantee short wait times, and our pharmacists will come out to greet you personally and answer any questions you have. If you want to be met with a smiling face, or even want someone to greet you by name when you walk through the doors, we are the pharmacy for you.
Call Almonds Drugs today.
443-3138 or 446-0014.
Well, hey, we're back. Oh, and she's calling right now. Somebody called during the break, and I said, call back, call back. Hey, this is Linda and Dr. Clay. How are you? Hello?
I'm fine.
Good, hey.
I'm a retired employee of Nash Healthcare System.
Okay.
And I worked in the operating room all those years.
Oh, okay.
So, I need a knee replacement.
Ah, well.
But I'm nervous about having it.
What are you nervous about?
Well, my husband had one, and he had problems. I know some other folks that had some problems. So everybody that has one doesn't come out better than they were before, but I know that's true with everything.
That's right.
But I just wanted to ask him where he got his training, and I just tuned in. And if he does knee replacements, then why I should go to him for a knee replacement.
There you go.
Going out of town.
Okay. Well, I'm going to hang up and let him answer that. Is there any other question you have?
I think that's the only one that I'm concerned about right
now. Okay, thanks. We're going to hang up, and then he's going to address that question. Thanks for calling.
So where I did my training, so my orthopedic training was in Memphis, Tennessee at the Campbell Clinic, which is affiliated with the University of Tennessee. It's actually the oldest orthopedic residency in the country.
Oh, wow.
But it had really high volume and a lot of things I was looking for in a residency. So I did 5 years there, and then I did my sports medicine fellowship in Jackson, Mississippi. And one of the reasons I picked that fellowship was, number one, their volume for sports medicine cases were higher than probably anywhere in the country. But also it gave me the opportunity to still do some total knee and total hip replacements while I was in fellowship, which is sometimes hard to find in a sports medicine fellowship. Because I wanted, when I came back, to still be, prepared to go in and do total knees and total hips. In terms of complications after knee surgeries and hip surgeries, certainly there are complications, and when they happen to you, they're a big deal. That's why in my practice, I tend to stress non-operative things to the max before I kind of pursue a total knee or total hip. I think it's really important that you exhaust all the conservative management and know for sure that nothing's working for you. And when you get to the point where you just can't live with your knee the way it is, that's the time to pull the trigger on getting a knee replacement. Certainly I'd be happy to see you in clinic. I think everybody in our group does a good job with joint replacements. Dr. McAvoy did a fellowship in joints. My dad does a lot of joints. And then, now that I'm here, I'm happy to do your knee replacement as well. But certainly if you're concerned about it, I'd be happy to talk to you in the office. My schedule's pretty available. I can see people if you called tomorrow, I could probably get you in either tomorrow or the next day for most things. But it's good to just have a conversation about, your symptoms and what you've had done so far, and kind of if there's anything we can do before we got to a knee replacement, and that's what I would suggest.
And I was going to add that a lot of people don't do well because they don't do their physical therapy, and I have no idea what what her husband went through, but I've seen that in my clinic where, this didn't work, and have you gone to physical therapy? Well, I couldn't do it. It hurt too bad, and it does hurt. Physical therapy does hurt. Yeah. But I think that's one of the problems.
Yeah, so it's a commitment. Knee replacement in particular can be pretty uncomfortable for the first 3 months, so you have to kind of push past some of that stuff in the beginning.
Hey, this is Linda and Dr. Nelson. How are you?
Good evening.
Good evening.
I've heard the previous caller, and as a matter of fact, welcome Dr. Nelson to Rocky Mount.
Thank you, thank you.
But I've had 2 friends that had knee replacement. They were to the point that they had no quality of life. They just could not even hardly get out of the car without and bend over or do anything without hurting. Both of them had surgery. Both are doing so well. I cannot believe my friend, I will not give his age, he is in his late 50s. And he is now, I forgot how long it was, I guess 6 months. I forgot how long it's been since he's had his surgery. But he has been out to Skyview skating rink.
Oh my goodness!
Skating like crazy. He's really bragging. My new knees. Look what I'm doing.
That is so funny.
And I would imagine, Dr. Nelson, that is good therapy for his knees, isn't it?
Yeah, as long as he doesn't fall.
Yeah, really. But I doubt he does. He's really a good skater. But anyway, so I've got 2 friends that have great success stories with knees. They were to the point, how could they not get it done? Or they wouldn't have any quality of life. They really wouldn't have. So anyway, just my comment.
All right. Thank you for calling. We appreciate it. Bye-bye.
Absolutely. Thanks.
Well, see, that's life, isn't it? You got 2 that say it's bad and 2 that say it's good.
So it's actually one of the more successful surgeries, but usually in the first 3 months, especially after total knees, can be pretty painful. But most people end up doing well.
I've not had this many phone calls. It's because you're so good looking, I think. Hey, this is Linda and Dr. Clay Nelson. How can we help you?
Yes, ma'am. I wanted to ask the doctor about the use of the injections you were talking about. Is it okay to get them every 3 months and use it as like a pain management, a preventive thing, and there wouldn't be any adverse reactions to it?
All right, that's a great question. I'm going to hang up on you and let Dr. Clay talk about that.
Okay, you want me to tell you what I get?
Sure.
Okay, I'm 75, and the 2 injections I get are Decadron and Depramedrol. And I want to know if it's okay to get them every 3 months or without any problem. Thanks.
Okay, thanks for calling. Well, that's another great question.
That's a really good question. So it is very safe to get steroid injections, which is what you're getting every 3 months. If you do it more frequently than that, it can have some bad effects on your knee, but it's in general pretty safe to wait 3 months and get a repeat injection without having any side effects. So that's a great option for people with knee arthritis or hip arthritis or shoulder arthritis. If you can get 3 months of relief reliably with a steroid injection, you can do that safe every 3 months and use that as your treatment instead of doing a knee replacement. The problem is sometimes that 3 months, shortens to 2 weeks, and then you're only getting 2 weeks of relief. And when it stops working that, for the full 3 months, then you have a time period where you're really hurting, and that's when it's time to start considering other options.
Mm-hmm. And he said, and both of those drugs he mentioned, they're the same thing, aren't they? Decadron and
steroid. Yeah.
Yeah, a steroid.
Yeah.
And what about if you're a diabetic? Is there enough of that steroid in there to really raise your glucose?
Yeah. So
your sugar.
Yeah. So if I have a diabetic, I usually ask them how well controlled their sugars are. As long as their sugars are relatively well controlled, it's pretty safe to do an injection. Mm-hmm. Sometimes, depending on their sugar levels, we'll cut down the dose of the steroid because it does have some effect on your body and it can raise your sugars. And so if you're diabetic, I typically tell everybody you got to watch your sugars closely over the few days after your injection, because if it gets elevated, then you kind of have to make adjustments on your medications.
Okay. And you know, one thing that I see a lot of too is carpal tunnel. Is there anything new? You know, it used to be brace at night and surgery. That was about it. Is there something else? So,
so typically what I'll do is bracing at night is a good first option. You can also do a steroid injection for the carpal tunnel, and that often will give good relief.
Hey, this is Linda and Oh. I don't know what happened. Call back. I think I pushed the wrong button. That's pretty normal for me to not push the right button. All right. Hey there, this is Linda and Dr. Nelson. How are you? Hello?
It's me again. I called a while ago,
Oh,
but I had
hi,
another
me.
question I thought of.
Okay. What's the question?
I've had people to tell me.
Turn your TV off.
I just wanted to ask Dr. Nelson, can I wait too long to have my knee done?
Okay. Anything else, Shug, before I hang up on you?
No, that's all.
All right. Thank you.
I get that question sometimes in clinic. It's very rare that you can wait too long to have a knee replacement. Certainly if your knee arthritis gets bad and it starts causing deformity of your knee, it can make the knee replacement more challenging. But you also don't want to be on the opposite end of going with the knee replacement too soon, because you don't want to do it when you're super young, because that raises the risk of having to have a revision in your lifetime. And so for most cases, you can wait as long as you can tolerate it.
So what is there, like, you're 35 years old, so that you're going to say we don't want to do one unless we absolutely have to?
Yeah, so
what's a good age where it would be okay?
Yeah, when you start getting I feel a lot better when people are in their mid-50s.
Okay.
So when even in late 30s, early 40s, late 40s, I'm still going to be a little bit nervous, because typically those patients are more active, and so there's they kind of beat on their knee replacements a little bit more as a person that's older. So it probably raises their risk of having to have a revision of that knee replacement or hip replacement in their lifetime a little bit higher, which is just a bigger surgery. And so if you can avoid having to have that done, it's always a good thing.
So we're going to kind of segue into some community outreach, and you do sports medicine here at the college. For those of you who don't know, our studio is here out at Wesleyan College, and Dr. Nelson does sports medicine for the athletes here. So tell us about that.
I did. So it's been kind of a weird year for sports medicine at the college, because they've been all over the place in terms of their schedules and what they've been allowed to do, and so it probably wasn't as busy as it normally is in the fall, not having football. But I will typically come out here most Mondays and kind of see them in their training facilities and just kind of evaluate them out here, and then some of them I'll bring to clinic if we need to. But it's been a good experience, and I've been really fortunate to be a part of their team and been able to work with them, and it's been fun seeing the athletes and kind of getting to know them. So that's been a good part of my job so far.
What, did you play sports in high school and college?
I did. So I played, well, not in college. I played some pickup basketball and things like that in college, but I played baseball and football in high school up until senior year, and then I just played baseball in my senior year.
Okay. Which I always wondered who gets hurt more, the football players or the soccer players.
So
baseball's kind of a little bit more safe, unless you get hit in the head with the ball, then you're in trouble.
Yeah, it's all different types of injuries. So definitely ACL tears are pretty high in soccer players, especially female soccer players. And so, but both have their different types of injuries, and the pounding on football causes some different injuries to come up.
Why is it higher in female? Are females built a little bit differently than males?
There's a lot of factors, some motor, just how when people land and how they pivot, and how the knee alignment of a female is slightly different than a male.
Oh, okay.
All kind of factor, all kind of factor in. And when you look how, especially in basketball, how women land versus men, the way they land is just a little bit more at risk. So there's been a lot of studies about trying to prevent that and how to train your body to land a little bit more safely to try to prevent some injuries. So a lot's going into that right now.
So is that part of sports medicine too, is training to not get injured?
Yeah, I think that's a big part of it. The therapists do a lot of that. The trainers have a big role in that, and so I think it's kind of a team effort between everybody trying to figure out what the best way is to prevent injuries.
Right.
And it's definitely in the past few years has been way more research into that kind of field of how to, we've done a lot of research on how to fix ACLs or reconstruct ACLs, but now we're looking at ways to hopefully prevent it from happening.
Right. Wow. Wow. I wanted to go back to knee replacement for 1 minute. Is it beneficial to do some physical therapy before your surgery if you can?
It does help a little bit. I think it helps with expectations afterwards on kind of what you're getting into. I think especially in certain situations, it can help make the surgery go a little bit better if everything's kind of tuned up before you go into surgery.
Okay. All right. Well, we got a couple more minutes, so tell us where you are, what's your phone number, what's your address, how do we get you, do we have to have a referral?
Sure. So most patients can go, most insurance will allow you to make an appointment without a referral. Some insurance companies do require that you see your primary care doctor first. In which case, when you call our office, our office staff would be able to tell you whether or not you need a referral or not. The easiest way to call is just to call our number in the office, and that's 962-4450.
You remembered.
Yeah, I glanced at the TV. So.
Oh, that's right. There it is.
So our office staff is really good at kind of handling questions on insurance and copays and whether or not you need a referral. Our office is behind the hospital. It's a standalone building now. If you just once you go into the facility, you just kind of follow the road to the right, and it's the 600 building in Nash Medical Arts Mall. But there's a lot of signs in once you get on campus to kind of point you in the right direction.
Yeah, it can be a bit intimidating if you're not used to it. There's a lot of buildings back there, but the sign, they have really good signage, so that isn't too problematic. All right, is there anything else? Oh, we were going to talk about robotics.
Yeah, so currently for knee and hip replacements, some facilities are going to using robotics. Nash currently does not have a robot, and there have been some talks about getting one. And there's some advantages of using a robot, and certainly if you were interested in that, I could tell you more about it in clinic if you wanted to discuss it. Unfortunately, Nash doesn't have one right now, but it's not the end of the world. But if it was something you would want to talk about, I could give you more information on it in clinic.
Awesome. All right. Well, thank you so much. It's been great. You've been a great guest.
Thank you.
He's a natural, isn't he? See? He has to come back again sometime.
Anytime.
All right. Thanks so much for watching. We appreciate it. Thanks, Dr. Clay, again for coming. And I want to shout out to his dad and mom who brought him back to town. That's awesome that we are blessed to have such high talent here. Y'all have a great week. Oh, and you know what? I wasn't here last week because I was tested positive for COVID. I never had one symptom. Made me so mad, but my husband was very sick. He was in the hospital with it. So anyway, that's why I wasn't here. But we will see you next week with more of Here's Your Good Health. Good night.